Aging. She manages the University for Seniors at AUB and is part of the 3LC team, the 3LC study team. Maya is also Help Age International Ageism consultant, so this is definitely her thing. Her research and advocacy work focus on human rights of older adults, of older people, their voice, healthy aging, long-term care, social protection, older refugees, and the impact on lifelong learning on older people's health, among many other things. Thank you so much, Maya, for today, for being with us. Our second speaker is Dr. Aja. He is an associate professor in psychology at the University of Edinburgh in the UK. Her research uses longitudinal and ecological momentary assessment methods to really understand mental health from a lifespan development perspective. Her work particularly looks at social and psychological influences on mental health across development. She's also a co-developer of the WHO Ageism scale. Thank you so much for both of you for being here with us today, and I'll give it to Maya. And I just want to remind everyone in the audience that you cannot unmute right now. If you have a question, feel free to put it in the chat box. Otherwise, at the Q&A, you can easily unmute and ask your question. Thank you so much.
Thank you, Adina, and hello, everyone. Thank you for attending today. I was personally very happy to see so many people register in this talk, and this shows really that the interest in ageism is gaining momentum, which is definitely by itself a big step in the right direction. So as Adina said, I'm going to be talking a bit about the why do we measure ageism. Amani, do you have my slides up? Yes, okay. I mean, is really measuring ageism a luxury in low and middle income countries, or is it a necessity? This talk series is about health and aging research in fragile contexts, in a polycrisis context, where really the priorities are so multiple and competing for the population at large, and more so when it comes to older people and to ageism. So we will be delving into what is ageism, the multi-dimensional nature of ageism, and why is it is it really important to measure it and to work on it. So in the first part of the talk today, we'll go over the definition, as I said, and then I'll ask you a few questions just for me not to be just talking alone, for some interaction between us. Then we'll go over the levels, dimensions, interventions, and then the determinants of ageism, consequences, intersectionality, and finally, I'll get a bit to talk a bit about the testing, the new WHO ageism scale in low and middle income countries, opening the floor to Asia to delve more and more into the scale and its development. So, what is ageism? Many people would think directly it's discrimination based on age-based discrimination. Discrimination is part of the ageism definition, but it's definitely one of three dimensions. So the definition, according to WHO, ageism is the stereotypes, which is how we think, the prejudice, which is how we feel, and the discrimination, which is how we act towards people on the basis of their age. And here I need to clarify that, of course, ageism can target any age groups. Our focus today is older people, but definitely any person at any age can be subject to ageism. I would also add to this definition that ageism is directed towards people on the basis of their age and is also directed towards oneself. And as we will see, self-directed ageism really has the highest negative impact on the health of older people, according to the WHO Global Report on Ageism, which was published in 2021, and which was really a milestone in advancing research and data about ageism. So, just a few questions so that I won't be just lecturing here. If you can put in the chat, but University for Seniors members, don't answer because I'm sure you know the answer to this one. Is the percentage of older people in Lebanon, older people age 65 plus, that is, in Lebanon is 6%? So just put true or false in the chat. So is it 6%? Is it less? Is it, okay, I did false. Okay. So it's false. It is false. It's much higher than this. It is actually 11%. And Lebanon is the fastest aging country in the Arab region. As you can see in the chart in front of you, this is the aging transition in the Arab world. The Arab world is still portrayed as a young region, but actually the figures and the data show that the Arab world is aging, and in some countries it's aging very fast. I can give you the example of Kuwait. Kuwait will complete its aging transition in 10 years. It took France 100 years to complete the aging transition. So we are all aging and we need to act. Next. Okay. So does ageism shorten one person's life by 2 years? Is it true or false? Do you lose 2 years of your life if you are subject to ageism? Do you lose 2 years? True. Okay, true. I have a lot of truths. Okay. False. I don't know. Okay, fair enough. I know. It's not 2 years. Unfortunately, it's 7.5 years, which is, I mean, very bad news. But at the same time, it's somehow good news because if we combat ageism, we can gain about almost a decade in life. So it's that big of an impact ageism has on the health of older people and people in general. Next, please. Globally, 1 in 5 people are ageist towards older people. Is that true or false? Anyone? True. Okay. So it's 1 in 5. True. Okay, 1 in 5. Okay. For those who said it's true, I have bad news. It's 1 in 2, actually. According to the WHO report, 1 in 2 people are ageist against older people. Data, we don't have data on younger people, but against older people, it's 1 in 2, and which shows how rampant ageism is, but also how invisible and silent it is. And this renders it even more dangerous on older people and on societies at large. Thank you, Aman. So we're done playing. Let's get to the talk a bit about the levels, dimensions, and the interventions. So I told you that there are 3 dimensions according to WHO definition: discrimination, stereotype, prejudice. But let's keep in mind that these 3 dimensions can happen on 3 levels: on the micro, the mezzo, and the macro level, which is, in other words, the individual level, the interpersonal level, and the institutional level. So every dimension can happen on every level. And Asia, in her presentation, will talk more about this. Next, please. So to go back to WHO's definition, let's try and dissect it a bit. And I will start with the discrimination. I'll start in the middle. I'm not going to start left to right, because the middle one, the discrimination, is really what we see at the surface. And this is what one thinks about when we think about ageism. It's what's visible to the human eye. Prejudice and stereotypes are below the surface. They are more invisible, and therefore they're harder sometimes to detect and harder to combat. So discrimination, I mean, it can be the language. We heard so much about COVID. During COVID, people were saying on the media, all over the media, don't worry, COVID only kills older people. So we can discriminate through language, we can discriminate through behavior by dismissing older people, by making decisions on their behalf. We can discriminate through policies, like we have age caps, for example, in health policies. In humanitarian settings, cash assistance or vocational trainings have age caps, etc. And discrimination through some laws in the banking sector, in the workplace, etc., etc. So as you can see, this is on the discrimination dimension. If we dive deeper, and we get to what is beneath the surface, we have stereotypes. And stereotypes are, for example, some very common stereotypes, negative stereotypes about older people, because of course you can have positive ones. So some negative stereotypes are older people are frail, older people are dependent, older people are needy, older people are a burden. And it's very important to say here that we know from research that stereotypes, they get into our subconscious mind since age 4. And we know from research that people who have these negative stereotypes, they could age in a more negative way. So that deeply rooted they are in our brains. That's for stereotype. When we go to prejudice, prejudice, as I said, is about how we feel. It's about the heart. Some examples could be when we feel pity for older people, or we feel anxious or uncomfortable around older people. This is to a big extent also driven by the fear of dying. We don't want to be around older people. We don't want to specialize in fields that have to do with older people, because we want to live our life hiding away from death. Although if we think about it, if there's no death, what purpose would we have in life? But that's a different conversation. So, and all these impact on the power of older people, whether it's the power within, the self-esteem, the power with, to do things with people, to change, etc., etc. But what is the root cause of ageism? The root cause driving the discrimination, the stereotype, and the prejudice. Help Age digged deeper. Amani, please, if we can move to that. And we created this lily pond framework about systemic ageism to see how the different systems and the different levels interact with each other, influence each other, to cause and to perpetuate ageism in a society. So at the surface, as you can see, you have discrimination, you have the language, the policies, the behavior, etc. If you go deeper, you will see the thoughts, which is stereotype, the feeling, which is prejudice, but you also see social norms, which are really the unwritten rules, the disempowering rules in society. For example, we consider that it's okay to decide to institutionalize an older adult, despite the fact if they don't want to be institutionalized. It's normal for older people to withdraw from the workplace, to leave, to retire. It's normal for older people not to have contributions, although we know that this is absolutely not true. But if we dig deeper, even deeper, we see that the root cause of all this is the value and the belief that we have that older people have less value than other people. And this is driven by the market logic versus the social justice logic that puts upfront or in priority the economic value of a person instead of our inherent human value that doesn't change or decrease with age, even if we are not producing. Although we know that older people contribute a lot, but these contributions are not recognized. They do caregiving, they do volunteering, they do mentoring. And even if they don't do anymore and they need support, this is their right and their value doesn't change. Next, please, Aman. This is an example from the Philippines during COVID, but due to time, we're not gonna just stop at this slide. So this is ageism. This is how we see it. This is how we live it. What can we do about it? The WHO Global Report on Ageism identified 3 interventions: policies and laws, education and awareness, and intergenerational connections. These are the 3 interventions that so far have been proven to yield positive results in combating ageism. And next, please. Due to the scope and the impacts and the importance of ageism, we see that international and regional frameworks have all spoken and given priority and shed light on ageism, whether it's MIPA, whether it's the UN Decade of Healthy Aging, and the UN Decade identified 4 priority interventions, and one of them is combating ageism, and this is why they created a global campaign to combat ageism. The Arab strategy on older people also talks about ageism. In Lebanon, I had the honor to draft the first ever national strategy for older person with Dean Sibai and a team of experts, and we put ageism and portraying a positive image of aging in many of the axes and at the core of the strategy. We also work at the University for Seniors on portraying a more positive image, on empowering older people, on working on intergenerational connections, as you can see in this picture, on pushing for laws such, for example, for pushing for a social pension in Lebanon, and all this to advance the rights of older people and combat ageism. Next, please, Amani. So quickly, what are the determinants, the consequences or impact of ageism, and the issue of intersectionality, also a word on that. So from research, we know that there are factors that increase the risk of perpetrating ageism against older people we are talking here. And some of these factors are being younger, being male, anxious about this, as we said, and less educated. Some factors, on the other hand, reduce the risk of perpetrating ageism against older people. And this has to do with certain personality traits like empathy, for example, and again, more intergenerational connections. Thirdly, there are factors that increase the risk of being a target of ageism, and these are being female, being older among older adults, being care dependent, and this also impacts on the issue of violence, and we will be talking about that. Working also in certain profession may put you at higher risk. Next, please. So what is the impact of ageism? As I said, in one of the first questions I asked was about how many years do you lose if you are subject to ageism? And we saw that 7.5 years. Why? For several reasons, because really ageism impacts on the physical and mental health of older people to a great extent. We know from research, but here I need to say that most research, unfortunately, comes mainly from high-income countries. And this is why such talks today are very important, really, to raise awareness and to give priority to research and data on ageism in LMICs. So it impacts on physical health. People who are subject to ageism, we know that they have a slower recovery from illness. They have shorter lifespan, as we said. They have poorer sexual health and management of STDs. And this is a big taboo when it comes to older people. They are even often excluded from data and research on STDs. Violence, abuse, and neglect. We know that 1 in 24 cases in the US 1 in 24 cases are reported when it comes to violence against older people. And this shows that really violence against older people is somehow accepted. And WHO published a report in 2022 on abuse of older people, and they identified ageism as 1 in 5 priority interventions to combat abuse against older people, because they saw that it is a risk factor. Plus, it's behind a low prioritization of the issue on the global level. We know from research that ageism is linked to higher depression. It definitely places access barriers to healthcare, whether it's physical or attitudinal barrier. There's poorer management of disease, there's health triage, age caps, as we said, and of course, fewer human resources, people who want to work in this field. So it is high time to recognize that ageism is an invisible social determinant of health. On the social well-being front, we know that ageism is linked to higher loneliness and isolation. It decreases also the voice and participation of older people, which directly impact agency and health at the end. Economic burden, we know that older people are at higher risk of poverty. Ageism impacts on their work, ageism impacts on their financial security. In the humanitarian context, unfortunately, in ALMEX, we are the witnesses of so many humanitarian emergencies in the world. And we know from the little research that is there that ageism increases in humanitarian context due to several factors, among which scarcity of resources, the stress in the community and the service providers. We know that only 1% of humanitarian funding targets directly older people, and that they are systematically excluded from humanitarian services. This is, I'm talking globally, not only in the region. And of course, ageism impacts and hinders the realization of the human rights of older people, whether we're talking about the right to be free from discrimination, right to health, right to care, right to autonomy. And this is at the heart. I mean, the right to decide where do we want to live, what course of treatment, what do we want to do in our end of life, in our life in general. And this is unfortunately very often taken away from older people. It impacts on the right to participate, the right to access justice, to be free from violence, abuse, and neglect, etc. And this is linked also to the lack of a global convention on the rights of older people, because human rights instruments in the world do not specify age as a basis, it's not ground of discrimination in human rights instruments. And because of the specificity of the rights of older people, we are trying to advocate for a convention specific for them, especially in these times when human rights are dilapidated everywhere. We need them today more than ever to have really a standard and a benchmark. Next amendment. Of course, ageism is not a free-floating bubble. It intersects, it interacts, and it is influenced by so many other characteristics. And this interaction really leads to compounded impact that accumulates throughout the life course, whether it's gender, whether it's disability, whether it's refugee status. And here we talk about double and triple and quadruple jeopardy, which amplifies with time and with age. Yes, I'm done. I still have one more slide, and I'll give the floor to Aja. So from here, because of all this, because of the scope, because of the impact on health and on everything else, it is high time to have an instrument to test, to measure ageism. And WHO came up with a scale that Aja will talk about in details. But for now, I'm just going to say a few words about testing this new WHO scales in fragile contexts in low and middle income countries. We are testing it as HelpAge and as with the University of Edinburgh, with Aja and her team who developed the scale. And we can proudly say that testing and validating the new scale was done in Moldova. We are done with it. And it was tested among older Ukrainian refugees in Moldova and older Moldovans, and the results showed, not surprisingly, that older Ukrainian refugees experience higher levels of ageism. In Libya also, we will be starting the testing soon. And here it's also a humanitarian context, because we will be testing among people who were affected by the Derna floods and people who were not affected by Derna floods. And of course, and proudly, I can say that proudly on behalf of all the 3LC team and UFS, we are testing in Lebanon the scale. We have translated it to Arabic, and our translation was adopted as an official translation by the WHO. And we have very recently started collecting data, and we're testing it as part of the 3LC study, of the big questionnaire of the 3LC. So we are looking at ageism and its interaction with other factors and psychosocial factors. The 3LC study, for those who do not know, looks at the impact of lifelong learning and other psychosocial factors on cognition of older people. So we will be looking at the correlation between this ageism scale and ageism and other factors like the childhood history, the experiences of war, loneliness, and we will see it and analyze it when it comes to health outcomes. So this is in a nutshell. And I don't know if you still think that measuring ageism is a luxury in low and middle income countries. I don't think so, personally. Thank you.
Thank you so much, Maya. And I think this is a great way to transition to Dr. Murray's talk. And then as a reminder, we're going to be taking all the questions towards the end of both of them, the session, all of it together. Dr. Murray, it's please feel free to take it from here.
Great, thank you. Let me just share my screen. Hopefully you see this. Yeah.
Yes, we can.
Okay, I don't see you anymore, so just shout me if anything goes wrong technically. So yeah, so I think Maya made a very convincing case for why ageism is something really important that we need to be tackling. So what I'm going to do is talk about how measurement is really crucial in combating ageism across the world, and particularly the role of the WHO ageism scale. So I'll try to move my slides on. So I'll first talk about a bit of background as to why measurement is so important in these efforts, and then I'll talk about the development of the ageism scale, how we're using it, and how we're hoping that in the future it can continue to contribute to combating ageism. So in terms of background, so in 2021, the first UN Global Report on Ageism was published, which Maya mentioned, and that was basically this massive, comprehensive review of the evidence on ageism, so the kind of state of the art in ageism. And it covered various different things, like what are the drivers of ageism, what's the scale of the problem, what are effective interventions, what are the impacts of ageism. But one of the things it also emphasised was the importance of having valid and reliable measures of ageism, because if we can't actually measure ageism accurately, then it's really difficult to know actually what really is the scale of the problem, who is most affected in terms of which people, which regions, which contexts. It's really difficult to understand the drivers of ageism if you can't measure ageism, and of course also its consequences. And really crucially as well, it's difficult to know, well, what are effective interventions, not just kind of programmatic interventions, but if the global community is working towards reducing ageism through policy changes and things like that, how do we really know if they're actually effective, if those efforts are working, if we don't have accurate measures of ageism? However, also as part of the report, there was a review of existing ageism measures, and the news was not very good there. So they basically looked to see, okay, what measures are in existence already and how are they performing? And basically there was a real lack of measures that were suitable for measuring ageism. In particular, there was a lack of measures that could capture ageism as we currently understand it. So Maya talked about the kind of three-dimensional model of ageism and the different levels of ageism. And existing measures weren't kind of consistent with that definition. They would maybe measure part of ageism, or their definitions were kind of outdated and didn't reflect our current understanding. And then another really, really important gap was there was a lack of measures that were appropriate for use across the world. They were very, very Western biased. They tended to be developed in like Western European context, or the US, in the English language, without very much consideration of how are these measures going to generalize to other contexts? How are they even going to be translatable into different languages as well? And then, as Maya mentioned, there's, we know that ageism affects people of different age groups, and there's good reason for focusing on older adults. We know that there are very detrimental impacts of ageism against older adults, but we do need to understand ageism against other age groups as well. And so there was a lack of measures that could do this. And then from a more technical perspective, there was a lack of evidence suggesting that these measures were actually functioning well in terms of their psychometric properties, so things like their reliability and validity. There just wasn't strong evidence to suggest that they were working well. So it wasn't very good news from that review. It suggested there was definitely a gap, and that was something that was echoed in further reviews that have been conducted since as well. So there was generally a consensus within the field looking at existing measures that we need some new measures to measure ageism well. That prompted the development of a new scale, the WHO Ageism scale, and the kind of design requirements for that was that it should capture ageism in all its dimensions. It should really crucially have a strong cross-cultural applicability, meaning that it would be valid and reliable not just within a diversity of different global contexts, but also comparable across different contexts as well, because it's really valuable to be able to compare ageism levels across the world, for example, to look at how different kind of policy contexts or cultural influences and things like that might be impacting ageism, and also just understand like how do the drivers of ageism and the impacts differ from context to context. And then another requirement was it should be applicable for different age groups as well, not just older adults. So to explain a bit more about the different dimensions of ageism that it was supposed to measure, it was viewed as really important that it should be able to measure stereotypes, prejudices, and discrimination. So as Maya mentioned, stereotypes is about how people think about others due to their age. So thinking, for example, that older adults are a burden to society, whereas prejudices are about their feelings towards other people due to their age, like feeling frustrated, or pity, I think Maya mentioned before. It might actually be positive feelings like enjoying older adults. And then there's discrimination, which is the behaviors and actions towards other people due to their age. And then there's the different levels at which it can manifest. So there's the self-directed ageism, which we might direct towards ourselves. For example, thinking, oh, I'm too old to learn a new skill, or I'm not going to do that thing because it's not really appropriate for people my age, kind of self-limiting our behaviors. There's interpersonal ageism, which is when it occurs between people. And then there's institutional ageism, which is more about the way that ageism is kind of baked into the policies, the practices, the cultures of different institutions. So through like policies and laws, but also the way that older people and people of different ages are portrayed within the media. And then another important distinction actually is between people's experiences of ageism. So the ageism that they experience as a target of ageism, and their perpetration of ageism, so the ageism that they display towards other people. It's really important to have that perspective from both perspectives, to have the full picture of ageism. So with these kind of design parameters, we developed the WHO Ageism scale. It was quite a lengthy process, a rigorous multi-stage process, starting with conceptualization, which was about agreeing on the definition of ageism that's going to underpin the scale, what's the scope and the purpose of the scale going to be. And then once that was agreed, we then generated items that conformed to that conceptualization. And actually, we started with something like 700 items. We had a huge, huge list of items, which were developed in collaboration with ageism experts and skill development experts from all over the world, because again, a really important thing was that the scale should be as universal as possible, because it was designed to be used across the world. Then we sent these items out for review from a set of experts, again from across the world, again with a background in ageism or scale development. and we got feedback on those items and used that feedback to improve them basically and get rid of the ones that were, say, like not very cross-culturally applicable. Like there was a few items where some people said, well, this probably doesn't really make sense in this particular cultural context, so they were deleted because of this focus on having a more universal measure. Even at that stage, we still had something like 300, maybe even 400 items. So the next stage after that was to select smaller sets of items to form particular ageism scales. So for example, what I'll talk about mostly today was the WHO Experiences of Ageism scale, which is a 15-item measure that focuses on people's stereotypes, prejudices, discrimination as they experience it from others. After the selection of the items, the next stage is then to translate it, collect data as as globally, as many contexts across the world as possible, and to do some psychometric analysis and check the validation statistics for those. So that's the process. This is a bit of a summary of where we are so far with our progress with the experiences scale. So the blue dots are the places where we've fully validated it. It's all written up and everything. And then the orange and red dots are in various levels of progress, like the data's being collected or is being collected, or we're kind of planning the data collection. We've got a reasonable spread, but as you can see, there are some gaps as well. Like we are still a little bit kind of focused in kind of Europe and North America. It's a little bit out of date. I think we've got a few more projects progressing as well at this stage. But yeah, in terms of the scale itself, so it's a 15-item measure, as I mentioned, that is about people's ageism experiences. So far, we've translated it into the 6 official UN languages, plus many other languages as well. And when we've been testing it, it seems to be performing well. So it seems to be that it's showing reliability, it's showing convergent validity and concurrent validity. So it's showing the patterns of correlations with other variables that we would expect it to show. Like, for example, it's showing the expected correlations with things like intergenerational contact and loneliness, things that we would theoretically think should be related to ageism experiences. And in terms of its content, I'm going to show you its content. I won't kind of read all of these out to you. You can find the scale and look at it in your own time, but it has one section that's about self-directed ageism. So that's that ageism that we might direct towards ourselves, and includes a mixture of stereotypes. So for example, at my age, my life has plenty of purpose. So that's a thought about yourself due to your age. We have I'm embarrassed of my age. So that's a prejudice. And then we have due to my age, I limit my participation in discussions even when they're about things that affect me. So that's a kind of form of self-discrimination. You're limiting your own behavior based on your age. And then we have interpersonal ageism, again, spanning stereotypes, prejudices, and discrimination. So things like others think that I have nothing valuable to contribute to society because of my age. Other people feel uncomfortable around me because of my age. And one thing to mention is that we try to include a mixture of both positively and negatively worded items to make it more kind of acceptable for people to do, because it could feel pretty depressing going through like a bunch of like really negative age-related stereotypes, prejudices, and discrimination. And although that's important to measure, because that's what we know has a negative impact on people, we also wanted to balance out a bit more with the more positive side of things as well. And then we have institutional ageism. So that's about, again, the policies made by the government, the way that people are portrayed in the media, things like being turned down for an opportunity are captured within that set of items. So we're also now working towards developing validating a scale that is about people's ageism towards others. So we're also aiming to have a 15-item scale that captures it from this perspective. So that includes items like older adults have a lot to contribute to society. I feel frustrated with older adults. I avoid spending time with older adults. So kind of similar in flavour to the experiences measures, but they're from the perspective of what are your thoughts, feelings, behaviours towards older adults. And it's going to be quite essential for having both of these together for understanding ageism from both perspectives, both the kind of experiences and perpetration perspective. how are we using these skills? What can we do with these skills? So most of the work so far has been more focused on the validation of the skills, but despite that focus, we've still already learned a lot using the skills about how ageism is interconnected with other things. So for example, in Colombia, we've been looking at, with Help Age International, the links between ageism experiences and older adults' perceptions of the age friendliness of cities and communities. And what we're finding is all sorts of interlinkages between people's experiences of ageism and the different aspects of their cities and communities in terms of how age-friendly they view them to be. We've looked at, as Maya mentioned, the ageism experiences of Ukrainian refugees in Moldova and find that they experience higher levels of ageism than local Moldovan older adults. In Serbia, Red Cross is using the ageism scale to test an intervention that's designed to reduce ageism. And as Maya also mentioned, we're also looking at the ageism experiences of older adults in flood-affected regions of Libya. It's been included as well in sort of cross-country consortium studies, like for example, the HILO study is looking at the links between ageism and healthy aging using the ageism scale. And very exciting, it's also been included as part of the 3LC study to look at ageism and how that links with other factors as well. So what we're hoping in the future is that now that we have a kind of validated experiences scale, that people will take it up and that they'll add it to their large-scale data collections, for example, existing national surveys, including longitudinal studies. And it has been taken up in a few national surveys already and longitudinal studies already, so that's really exciting. Because 15 items might be a bit too much sometimes for some data collections, we've also developed a 5-item version where space is more limited, and actually potentially a 1-item version people can use as well if they're really constrained for space. We looked at in a recent review actually, like what are the options if you want to include an ageism measure in a large scale, especially cross-national study. And we found that there really aren't very many good options and that the ageism experience scale seems to be the best option. It's the only one, again, really that measures all of stereotypes, prejudices and discrimination. And then other efforts we're continuing to try to translate it into more and more languages and to use it in further global contexts. Actually, we have a translation guide available so that if people want to use it in a context where there isn't currently a translation available, they can translate it and use it in translated form. I think it would be really nice also to see it used more as an outcome measure for policy and programmatic intervention evaluation as well. I think that's one of the main ways in which it can kind of add value and contribute to combating ageism. And as I mentioned as well, it was actually designed for being used with different age groups. And we don't actually know very much about ageism against younger age groups. And I think part of that is we don't have a very good way of measuring it. So we're hoping that once we validate it for younger age groups as well, that it might get taken up a bit more to be used across kind of mixed age or studies as well to understand ageism across the lifespan. To sum up, good measurement is, I would say, really essential to combating ageism. We really don't know what works unless we have a good outcome measure of ageism. And what that means more specifically is that we need measures that reflect the multidimensional nature of ageism, that acknowledge that it can impact all age groups and, really crucially as well, it affects all countries across the world. So we need ageism measures that are kind of universal in their applicability. And I'll just finish by saying that on the 3rd of March, we're going to launch the WHO Ageism Scale with WHO. Everybody's invited if you want to register for that webinar. You can do so at the link there or the QR code as well. And I will stop there.
Thank you so much, Dr. Murray, again. And also, again, another big thank you to Maya and Dr. Murray together for this like amazing presentation that has both perspectives and like general knowledge about ageism, but also like more applied and the how. So exactly the how and the why. So I just would like to remind everyone, we have about 10 more minutes left. I want to remind you all that you could unmute at any point if you have a question, or you could also put it in the chat. We'll try to monitor the chat. Before I see some hands already raising, before doing that, I just wanted to say that, you know, going back to Maya's, I'm going to take the freedom to ask my first question. And like just a note that Maya, as you mentioned, really like data collection on ageism, and like all we know is mostly based on high income countries, especially for in terms of like effects on outcomes and things like that. So I'm really excited that as part of the 3LC study, we are collecting data on ageism in Lebanon. And given that Lebanon is spearheading in the proportion of older adults in the region, this is going to be really, really novel and really filling an important gap. So I'm glad about that. And thank you for pushing for us to have that ageism scale in our study in the questionnaire. For just one quick question to you, Maya, is I don't know about any initiative. I don't know if there's any initiatives in Lebanon to kind of fight, you know, or just to think about ageism and how to prevent or to work, you know, with folks who are facing ageism in day-to-day lives. Do you know of any initiatives in Lebanon?
Unfortunately, yeah, thank you, Adina, for the question. We're very excited about testing it. The little we know from Lebanon and from the region is more qualitative research about ageism, and especially from Help Age's experience and work. In Lebanon, unfortunately, this is a topic that has been invisible, and the term ageism has been coined by Robert Butler back in 1967, and we had to wait until 2021 for WHO to issue this global report, and ageism is still, up until today, to our knowledge, not translated as a word. Like in Arabic, we say التمييز على أساس السن. It's a whole phrase. Unlike sexism or racism that have a translation in all the countries practically. So it still is invisible. In Lebanon, I can tell you that at the University for Seniors, this is at the core of what we do. And our mission and vision, we want to portray a positive image of aging. We want to work with older people, not for older people, with them, so that they raise their voices, they know their rights, they advocate for them, they push for them, because nothing for us without us. So we're trying, but of course we cannot do everything. We cannot reach everyone, you know, our resources, but that's why such talks are important, to raise awareness and push people and older adults to act.
Okay, thank you, Maya. I will try to do one chat, one actual question by raising hand. And I think that just that answers what Maya, you said, answers what Lina and Whitehead has asked, which is, are you implementing any program in Lebanon or still collecting data? Maya answered about the implementation of programs. And in terms of collecting data, we are very excited that we are in the field trying to collect this kind of data, which will be definitely novel. I'm going to move to Rima Habib. Rima, if you want to please unmute and ask your question, and then I'll go back to a question from Dean Sibari. I think for Aja would be that question.
Thank you very much, Adina. And my name is Rima Habib. I'm from the Faculty of Health Sciences. I am a professor here, and I enjoyed your lectures, your seminars extremely. It was very simplified actually, complex concepts made very simple. So thank you for that. I have worked on children, on workers specifically, and on children. And I have written a chapter on intersectionality to be used in the field of occupational health to encourage scholars and researchers to use this concept and this framework. In that perspective, the framework would be to include gender with race, with socioeconomic status, with the different identities that the workers could have. Would that be the same? Because Maya, you mentioned intersectionality, but I'm not sure you had the chance to elaborate much on that, the concept and how it's being used in this field, in the area of your research. Could you please elaborate a little bit more?
Yeah,
Thank you.
thank you, Riva. Asia could also, if she wants to add, how in the analysis they are looking at the intersectionality, whether it's gender, it's SES, and other things. What I was talking about is that it's not only about age. So we know and we see on the ground and from literature, when you are an older adult, when you are an older woman, when you are an older woman who has a disability, when you are an older woman who has a disability, who is a refugee, you suffer from these multiple disadvantages that lead to these compounded results. So therefore, we need to look at all these to be able to properly analyze and to properly design interventions. Like in Moldova, for example, we saw some differences when we tested the scale among men and women. In Colombia, we did not see this difference. So an intervention to combat ageism in Moldova will not look like an intervention to combat ageism in Colombia, for example, and will hopefully, as the year passes, we'll have data from Lebanon and we will have more information and we will be able to more inform interventions and policies. That's the hope.
I'll
Thank
just
you,
add,
Maya.
sorry, if I could just add something really briefly as well, because we kind of recognize the importance of intersectionality. We do always try to, alongside measuring the ageism scale, when we're doing these validation studies, measure things like gender, disability, ethnicity, socioeconomic status, because it's really important to understand not only how ageism differs by these characteristics, but how that might also interact with them in terms of influencing health outcomes, social well-being outcomes, etc. So yeah, we always try to capture these things as well in the data collections.
Thank you, Aja and Maya. I think, Aja, this next question would be for you from Jean Sibai about testing the scale. It is a unique setting, testing if among a certain group, socioeconomically or not, which is rarely researched in the literature. I don't know if it was potentially a comment or something you want to add here.
Yeah, so the way...
Go ahead. Go ahead.
I was going to say, the way that we designed the scale was to be as universal as possible so that it could be used across different settings. But we didn't design it to be used in, for example, like a healthcare setting or like a labor market setting or something like that. So it's meant to be a kind of general ageism scale. But what is really valuable is to kind of validate it in each of these settings as well to make sure that it is actually functioning well across different settings and different populations.
Yeah, and maybe Aja, you can also answer the next question from Deborah John about when will the WHO Ageism Toward Others scale be available for other research? If you guys know, haven't.
Okay, well, yeah, hopefully soon. So we've collected some data which we're using to kind of choose the final items. So we've kind of got it down to 19 items and we want to choose the best 15, but we want to make sure that the selection takes into account different settings. So I think I would estimate maybe within the next couple of months that we'll have that finalized and validated for people to use as well. But in the meantime, people are free to get in touch, and we're happy to make it available on a kind of with the caveat that it's not fully validated yet and there might be modifications. So yeah, feel free to get in touch if there is interest in using it.
Thank you so much. I don't see any more questions. Abla, right? You had one more? Okay, sorry.
Yes, I have a question. Actually, in the chat, there was a comment that testing it among in the 3LC study is very unique in the literature because we will be testing it among relatively high socioeconomic status. So it could be, a unique added value to the literature. But I have a question for you, Aja. It's about when you were developing the scale and coming up with the 15 items, were there a kind of a conscious decision to include proportionally, for example, from the three types of ageism, like the feeling, the thinking, the acting, and across the different levels, whether it's at the individual level or institutional level, or just it was a kind of a scientific without, agreeing about these items without going into a conscious decision about whether we have a proportional inclusion of all the three different types of images.
So the items were generated according to this three-dimensional model. So we actually found that it was much easier to generate items for stereotypes and discrimination because there's so many different ways in which they can manifest, whereas prejudices, we struggled to come up with a very large number of items because I think maybe our feelings are more limited than our behaviors and our thoughts. So when it came to the final scale, we did try to have a relatively even spread across these three domains. But it was interesting to find that I felt like we were losing a lot from the discrimination and the stereotypes by getting it down to those items, whereas I felt that was also with the prejudice items because we didn't kind of generate so many in the beginning. So I think the basic answer is yes, we tried to have a pretty even spread across these three domains. Yeah.
All right. Thank you so much. This was for such an exciting, really talk. And I would like, Imad, sorry, I'm just seeing you unmuted. Imad Tapsh, did you have a question?
Actually, first of all, thank you very much for this session. Very nice, very informative. I don't have a question, but I'm just going to tell you something personally. Joining UFS was a very nice experience for me, and it encouraged me a lot. I have to tell the ladies that I submitted for my master's in history. I was, very taken by the subjects of the UFS, and I discovered and worked on myself and decided to go and join back to AUB and resume my studies, and hopefully they will accept me as a master's degree in history, hopefully. And inshallah, maybe, I don't know, maybe I might be an example for my fellows, other fellows to join me also and take the step ahead. As I said before in an interview with UFS, learning doesn't stop at a certain age. Every day you learn something new. No matter how years you spend, you still have the time to learn something new. I'm 67, but this number doesn't mean anything to me. Thank you very much for all of you.
You should be proud of the number, Imad. Sorry, Adina, if I may. You are an example to all of us, Imad. Thank you for sharing your experience. And I know that many older adults are attending today, UFS and non-UFS, and it starts with you. It's important what we're doing and trying to do at a global level, at a national level, but we cannot wait only for governments. It starts with you. And self-directed ageism is the most harmful. You need to know that you can change, and you can change yourselves and the world because you are worthy of it. And you're full human beings, no matter what the world tells you. So we all are.
But I want to second Maya. Thank you so much, Imad, for sharing. It's very heartwarming, and best of luck. Fingers crossed that you will be admitted into the history program. If not, let us know. But I just want to really thank everyone for joining us today. This was a great, again, a big applause to our speakers for today. And please stay tuned for more webinars that will be coming. And have a great evening, everyone. Thank you so much. Take care.
Thank you, everyone.